It's really my pleasure to be here to talk to you guys about what we do in interventional radiology. These are my disclosures, and really my goal for this talk is pretty simple. I just hope by the end of this you can answer this question, which is what is an interventional radiologist, and more specifically, what can interventional radiology do for folks with kidney cancer? So let me give you a little bit of a definition. To me, an interventional radiologist is a doctor who uses imaging to help with procedures inside the body. We are not surgeons. We don't do the things that Dr. Mateen showed. We do everything through little pinholes through the skin. So we don't make incisions. There's no stitches. It's just a small nick through the skin, and we use imaging to watch as we march a needle down right to where it needs to go into the heart of the tumor. So at the end of the procedure with one of us, usually you just have a Band-Aid to show for it, but we can do a lot on the inside. And as Dr. Mateen and Dr. Campbell mentioned, one of those common things we do is a biopsy. So we use our imaging, whether it's CT or ultrasound or PET or MRI, but the goal is to get our needle through the skin right into the heart of that tumor. And when we do a biopsy, we use that needle to take samples out of the tumor. So this diagnostic procedure is something that we do very, very commonly. And we use it for answering different questions, for patients at different points in their cancer story. But when we have a needle inside the tumor, we certainly can do more than just take tissue out. And as Dr. Campbell mentioned, one of the things we do with our needle in there is we can kill tumor by delivering energy to it. So that's a procedure we call ablation. And there's all different flavors of ablation because there's all different types of energy. We can electrocute it, we can burn it to death, we can freeze it to death, we can starve it of its blood flow, and we can even deliver some radiation into it. So we're a little bit like the Swiss Army knife of medicine. We have these tools that are sort of very diverse, and it just depends on each particular patient and where they are in their cancer journey. And we might just have the right tool for that patient up our sleeve. So I'm just going to run through the different stages of kidney cancer and where an interventional radiologist may fit in. I think the most common place where folks may interact with an interventional radiologist is when they have early stage RCC. Tissue sampling, which is another fancy way to say biopsy, is a very common procedure for us to do with patients with early RCC. And actually, this is one that's very close to home. My dad has an early stage RCC. He presented with a small renal mass, which Dr. Mateen talked about. We saw one of Dr. Mateen's colleagues, and we sort of discussed the various options. For us, we wanted to know what it was, so we did a biopsy. And my colleague in my department did the biopsy. It came back as positive for RCC, and he's now in the active surveillance program here at Anderson that Dr. Mateen mentioned. So this is something that we do very, very commonly. And so that's probably a very common touch point for patients to see an interventional radiologist. Another thing we do, though, is we do ablation. So like I said, we put a needle into the tumor, and we will burn the tumor to death or freeze the tumor to death. And the goal is to be curative. So for patients with small renal masses that we can treat completely, ablation is a very good option, and I'll show you what examples are for that. Dr. Mateen showed some incredible surgical videos and images. And so one thing we do for patients, particularly when they have a very large tumor, is we'll do something that helps decrease the blood flow. As Dr. Campbell mentioned, one kind of hallmark feature of renal cell carcinoma is it's really addicted to its blood flow. And so it has a lot of blood flow. And when someone takes it to the operating room, like Dr. Mateen, bleeding can be an issue. So one thing we might do is stop the blood flow to the tumor just to make the surgery a little less complicated. Oligometastatic RCC is actually something that the next speaker, Dr. Tang, is an expert on, and he has fantastic studies and examples to show in that. So I'm not going to spend too much time on it, but to sort of define what I mean by this is when patients have the cancer spread beyond the kidney, but only in a handful of sites, and in sites that potentially we can clear and we can kill the tumor, whether it's with radiation or with surgery or with ablation. So this is sort of a little separate category of patients who have disease that spread beyond the kidney, but in locations that we could potentially get rid of. And so, as I mentioned, Dr. Tang will spend more time on this, but ablation is something that we consider for these patients in this special category. And then, of course, are all the patients with advanced RCC. So again, biopsy is important here. Usually the question we're answering here isn't, is it cancer or is it not cancer? We already know that it's going to be cancer, but we're going to be doing biopsies for patients in this category to answer a couple questions. One is, for example, all these molecular therapies that we have nowadays, we need to know, does the tumor actually have that sensitivity to that specific molecular therapy? So the way we answer that question is by taking some tissue out and doing all the molecular analysis of that tissue. And that way we can say, yes, this drug is going to work, or no, this drug's not going to work. And then a lot of the procedures we do for the patients in IR is focused on pain palliation. So in particular, I'll show you examples of what we do for folks when the tumor spreads to the bone. Kidney cancer loves to go to the bone, and that can be a very common site of pain and poor quality of life. And so we have tricks up our sleeve that can help with patients with these bone metastases. So let's start with early stage RCC. So this is just a screenshot of the national guidelines for how we manage patients with early stage RCC. It's very complicated, and I try to sort of simplify it by putting a box around stage 1. So this is stage 1 RCC. So these are patients where the tumor is still inside the kidney. And so the primary treatments that are recommended are partial nephrectomy, which Dr. Mateen mentioned, and then ablation, so ablative techniques. And so ablation is a very common procedure that we do for patients with early stage RCC. And that's because the data is very good. So we know the local control rates, meaning how effective we are at killing the tumor completely. And for tumors that are small, our ability to kill the tumor is as effective as the surgeon's ability to remove it with a partial nephrectomy. It's a low risk procedure. The complication rates are low, and we like it as well because it doesn't require taking out the entire kidney. We can spare the normal renal tissue, the normal kidney tissue, so the function of the kidney isn't necessarily decreased. So this is what an example of ablation looks like. So we are imaging physicians. Everything we do relies on imaging. And so when you come into an interventional radiology suite, you are literally inside an imaging machine. So you're inside a CAT scan machine, just like you've had CAT scans before. So this is a patient with a small renal mass, which was proven to be a renal cell carcinoma. And in this case, we froze it to death. So this little snowflake just shows you what we're doing, sort of in a cartoon way. But the idea here is that we freeze the tumor. The needle that we stick in this tumor gets to about minus 150 degrees Celsius, which is very, very cold. It's lethal to everything. Tumors are no exception, and we can get rid of the tumor that way. Again, we're inside a CAT scan machine, so by the end of the procedure, we want to make sure with our imaging that that tumor is totally dead. So, before the patient gets off the table, we've done repeat imaging to make sure that we were able to completely cover that tumor. When tumors are a little bit larger, we sort of take a belt and suspenders approach. So this tumor is a little bit larger. It's about 4.5 centimeters. And like we talked about, these tumors get a lot of blood flow to it. So one thing we do in this case is we belt and suspenders it. So we do something called embolization. Embolization is this image here. The way this works is we find the tiny blood vessels that are supplying blood to the tumor, and we shut them down. We deliver drugs into those tiny little blood vessels that starve the tumor of its blood. This way we can take advantage of the fact these tumors are addicted to their blood flow, and we can starve them to death. And at the same time, we then also do the ablation, which in this case, we burned it to death. So this is our little flame inside the patient. And so we can try to combine both the starvation approach as well as the burning approach to be as thorough as possible to kill these tumors. This is something that we do in one setting. So it's, when patients come in, they go to sleep and they wake up when it's all over, and we've done both of this at the same time. The last scenario for these patients, the early stage RCC, dovetails with the last procedure that Dr. Mateen showed, which is when you have a very large kidney tumor that at this point has invaded into the vein and is crawling up the major blood vessel in your abdomen going up towards your heart. Dr. Mateen does the surgery which he showed you, which is that sort of honestly a heroic procedure where they remove the kidney as well as the blood clot. It's extending up to the heart. So it's a very sort of maximally invasive procedure. And to help them out, what we do is this embolization. We starve the tumor of its blood flow so that there's less blood loss in the operating room. So let's move on to this oligometastatic category. Like I said, Dr. Tang's going to spend a bit more time on it. But in this category, again, when we look at our national guidelines, we have the recommendation to do surgery or radiation or ablation. And so, again, if we can eradicate all of these sites of disease in these patients who just have a handful of spots outside of the kidney, then we can potentially help their outcomes. So here's an example of one of these patients. This is a patient who had kidney cancer. She had that right-sided kidney removed, and now she has a small spot here, just sitting off in the corner of the abdomen that we've seen it grow over time, and this is definitely a little spot of tumor that's just taken root and is starting to grow. So there's several options here. Of course, they could go back to the operating room to remove this, but once you've been in the abdomen, it gets more challenging to go back in a second, third time. We could potentially radiate it, or we could do what we do, which is ablation. When we do ablation, we're not surgeons, so we don't have the ability to kind of get our fingers literally in there and move things around, which is an important consideration because all these white noodly things above us, that's all loops of bowel. So when we do our ablation, of course, we're killing the tumor, but we have to be careful about the normal tissue too, because normal tissue will also be injured if we freeze it or if we burn it. So we need to be careful about this, but we have some creative ways to move things around. So this is what we call hydrodissection. We put a little bit of fluid in the belly, which creates some separation between where we want to work and where we want to protect. And so we can push the bowel away just with little needles through the skin, and we can make our ice ball cover the tumor and be as thorough as we want to be to kill the tumor. So one common question patients ask is, well, what happens to that tumor? So I understand with surgery, you take it all out and it's gone, it's in the bucket. But with ablation, where does the tumor go? And the answer is it doesn't go anywhere. By the time the procedure is over, the tumor is dead. But it takes a while for your body to clear that up. So essentially the immune system that Dr. Campbell mentioned now has the cleanup job. They're kind of like the garbage disposal of the body. They go in there and they gobble up all the dead tumor cells, which over the next weeks and months and years will shrivel up and shrink away into a scar. So this is that same patient. This was the original tumor, as you can see, and then over time, it just disappeared into nothing. And so that's what happens over time, is the tumor essentially just disappears, but nothing happens overnight. Like I mentioned, the bone is a very common site for renal cell carcinoma to spread to. And so we end up doing a lot of interventions for patients with these bone lesions. We've seen how effective our procedures in terms of ablation are for local control of the tumor. But when we talk about patients with advanced disease, really our goal is not just to kill the tumor, but also more importantly, to help with the pain that these areas are causing. So if you have a procedure with us, this might be the sort of room that you come into. This is what a modern interventional radiology suite looks like. And like I said, everything we do is with imaging. So just to orient you, we have a CAT scan machine in the room. We have a live x-ray machine in the room. We have an ultrasound machine tucked in the corner. And we even have a tower here for endoscopy, which is to use little cameras to take pictures inside the body as well. So we bring all of this to bear on the patient. So the patient stays here, and then everything comes to the patient as and when we need it. And this is the sort of things that we do in this setting. When patients have advanced cancer that spreads to the liver, it's something that we try to be a little bit aggressive about because we don't want the disease in the liver to get out of hand and lead to liver failure. That certainly is a very morbid and a high mortality scenario. So when patients have spots in the liver, we do procedures like ablation and embolization to clear the tumor. So in this case, this is the liver outlined right there, like a big comma. These are the ablation needles that we put in under our imaging guidance to kill it. This is a microwave ablation. So just like the microwave in your kitchen gets very hot very fast, the tips of these needles get very hot very fast, and we burn the tumor to death on the inside. And before the patient leaves the room, we make sure that tumor is gone. Like I said, the bone is critically important here for patients with advanced disease, and so we do a lot of procedures for the bone. This is a patient who had a tumor that spread to a bone in the pelvis. So you can sort of see this bite's been taken out of the bone right there. That's where the tumor is. And that's what kidney cancer does, is it really just chews away at the integrity of the bone. So we want to stop it in its tracks. We also want to help with the pain that it causes in the bone. So here we do something called a cryoablation. Like I said, we freeze the tumor to death. This is just a needle that goes right into the bone and kills the tumor that way. When it involves bone that is important for weight bearing, then we need to do something else besides killing the tumor. So this is a spot that's in the hip bone. So the hip is a ball and socket. So you have the ball, which is your leg bone, and then you have the hip, which is the socket, which is like a cup around it. So when it involves that cup around the hip bone, it can be really painful every time you stand up. It's just rubbing and hitting against that tumor, and that bone has become so weak, we need to reinforce it. So this is where we not just kill the tumor by freezing it, but we literally get a little cement mixer and we mix up some cement and we pack the weakened bone with bone cement. So this way we can address both the tumor, which is the root cause of the problem, and we can address the weakening, which is the consequence of the tumor being in the bone. When tumors are quite large, so here's a bone that's involving the hip joint that's just all around it, just encasing that bone. This is when we take a kitchen sink approach, which is where we do the embolization to kill the tumor by starving it to death. We do the cryoablation, which is where we freeze the tumor to death. And then we, again, take out our cement mixer and pack the whole area with bone cement to try to be as thorough as possible. And then lastly, I'll just show you this case. Sometimes we have to which would actually break into our carpentry toolkit. So this is another lesion in the bone that's quite large, and it's involving the pelvis. So every time this patient moved and stood up, it was causing pain. And so we literally take our carpenter's tools, mallets, and screws, and we reconstruct the pelvis using these, just like you might in your garage. So this is what a screw looks like under CT. Here's the big screws that go through the bone, and this way we can sort of reestablish the integrity of that bone with these tools. So hopefully I've given you a flavor of what interventional radiology is and what we can do in terms of applying a very diverse toolkit for patients with renal cell carcinoma, and just underline the fact that these local interventions can have important ramifications for folks, including for quality of life. And I'll end there. Thank you very much.